Let me first begin, if I could, with Professor Watanabe. When you talk about guidelines and you say that we have to be doing more to make them not just a cookbook experience, what do you feel right now about the overall quality of guidelines that are being used for hip fracture care? And I know you presented a nice storyline of what we should be doing for hip fractures, but what do you think is the biggest problem with the way guidelines are developed right now?
There is many problems, and first of all, it's a very expensive cost problem, and another problem is as I talked in my presentations, the guideline is now in Japan. The guideline is paper-based. Paper means the real book.
Yeah.
But I think the update is very slow. So I think I'd like to change these conditions. For example, the everyday updated, and it is easy to use the web-based presentations.
And you're absolutely right. I think in my own mind, I think the most difficult situation with guidelines has been the relative period in which they are renewed. So we can take, let's say, the American Academy's guideline, or pick any of the big ones, right? Or the Japanese Orthopedic Association may have guidelines as well as I know. It's years, not months. It's several years. In some cases, up to 7 or 8 years where one guideline has not been renewed. New evidence comes up. And when new evidence comes up, we have to be able to incorporate. Yes. So I think that's absolutely the way to go. Go ahead.
So I think the monitoring of the evidence is most important.
Yeah.
Real-time monitoring of the evidence is most important. So I make the systematic review committee under the umbrella of the JSFR.
Well, let me ask you, I noticed that I see someone on video here. So I see Mark Phillips. Mark, can you unmute for a second? I know you, tell us about what the work you're doing with guideline development specifically, and maybe not related to guidelines per se, but Professor Watanabe just openly said that they have built in the systematic review committee within a guideline. How important are systematic reviews or meta-analyses as part of getting to the best evidence in your experience?
I mean, extremely important. And like you showed, there's a lot that goes into that in looking at the quality of that evidence and then having the guideline clearly sort of portray, the quality of that underlying evidence so that people are informed. And obviously, as both of you mentioned in your talks, it's a lot of work to do that. And then, could be very quickly after. There's always new evidence coming out very quickly. So it's a constant, battle to keep renewing that. And it's something that obviously you've thought a lot about in creating a team that is looking to specifically keep up to date on that.
One thing I will ask is, we are now in the era, not even of systematic reviews and meta-analyses, but network meta-analyses. And I don't know if anyone here has been using network meta-analyses or has been using them as part of their routine. Mark or anybody else who has a comfort level with the terminology, can you explain to our members on this event right now what a network meta-analysis is and how it differs from a systematic review? Or I don't know if Natsumi or someone else wants to speak to it, but I know Mark knows a lot about network meta-analysis.
Yeah, I can speak to it if others don't. And that was a question I had about this guideline is if a network is something, you'd maybe consider. Essentially, like you showed, the meta-analysis comparing two treatments. Through the network meta-analysis, you're comparing any number of 3 or more options or treatments. So as you can imagine, for hip fractures, there's more than 2 treatments out there, 2 options. all of those can be compared in sort of one meta-analysis. And that's a way to sort of get a whole picture of everything that's out there. So that's kind of the approach of the network meta-analysis, opposed to a individual meta-analysis for each sort of each option separately.
So the one thing that we have been always saying historically, right, is a guideline should have the best available evidence. And the best available evidence, we can argue, can come from a randomized clinical trial. Let me just stop there for a second and ask anyone else who's on this panel today, what do you feel should be included in a guideline? Should it only be randomized trials? Can it be prospective studies that are comparative? Can it be a case series? What is the threshold for the quality of evidence that we should be including or mandating in a guideline that would make it believable and trustworthy? I'm curious what other people think. It's hard online to guess, so I don't want to name someone to say something, but if someone has a thought, please do unmute and let us know.
So I'll I guess talk again. I think it's probably always a good approach to maybe start at the RCT in terms of the systematic review team and see what's out there. And the way I think of it is kind of a stepwise approach. Find the RCTs that are out there. You know, the question is still somewhat unanswered or uncertain in the RCT evidence. Move to sort of the observational and you know, kind of work down. Obviously, it's dependent. Certain clinical questions are, you know, unlikely to have a ton of RCTs out there. So you can't, I don't think, be very strict on exclusively RCTs because some questions won't have anything. But
again, so Natsumi, let me ask you this then. In a situation on a question for a guideline, if you do not have a randomized clinical trial, what do you do at that point? Do you just say, okay, we won't answer this question, or we will just downgrade the quality of the evidence? What's the strategy we use? Because in orthopedics, we all know that we don't always have randomized trials for every possible question.
Right. So as Mark said, some clinical question or some clinical questions, he is unethical for some clinical questions. And in that case, we just go to the observational studies. And I think even in the observational study, we can evaluate the quality of evidence. So if we do not have the RCT in certain types of clinical question, it's very important to evaluate the quality of the study, even in the observational study.
Absolutely.
Yeah.
I agree with Natsumi. And for example, the complications after surgery, it cannot be done by the RCT, and the big, large cohort is very important to study design, I think.
Yeah, I think you're right. I mean, when we talk about the difference between a randomized trial, and that's for evaluating the outcome of a treatment. But if you're looking at what factors predict an outcome, or you're looking for surveillance, probably an observational study is going to be a better option for you. As you all know, hip registries and hip fracture registries have been very popular. The challenge with hip fracture registries is maintaining quality of data in that registry and being very, very careful to evaluate those sorts of things. Let me ask, if I could, and let me also ask Dr. Petrosvary, I noticed that you've unmuted. Did you have a question?
I did have a question. Just again, a blanket statement to everybody. Please put some questions in the chat if you need to. But the question that I had was, how do you weigh the evidence that you've got versus the expert opinion that forms the guideline to let people know okay, we don't have great quality evidence, so this is mainly expert opinion, versus we have great evidence and that's what it's based on. For the end user, is there a sense of where the guideline is coming from? Because at the end of the day, we have, oh, this is a B recommendation or an A. But do we have a sense of that portrayal of the evidence quality to the end user?
Well, I guess what I'm hearing is how important is bringing in the expert opinion and the consensus group on top of the evidence when you're developing a guideline.
Yeah.
Has anyone been involved? I mean, I know, I'm guessing Natsumi, you've been involved. I know Mark has been involved to some degree. We've been involved, and I'm pretty sure Professor Watanabe has been involved. But are there others on the panel who have been involved in a guideline development or involved in reviewing guidelines? Is there anyone developing a guideline, working on one right now? But you're thinking, okay.
No one here in Japanese guideline.
Okay. So, but it's good. I mean, it's still important. It's an important situation, right? Because we have these issues where you either read or you're reviewing a guideline. How do you know a guideline is really good? Now, you presented a very nice, simple checklist in your presentation, but it might be worthwhile going through it. I think we can argue that the quality of the evidence is first and foremost. You have to have good evidence. And if we take a step right there, and let's use hip fractures. When you look at hip fractures and you look across all the treatments, what do you feel, for those of you who are looking at hip fracture care and hip fracture treatments, how are you making decisions about how to treat these fractures? Where does your evidence come from? Are you reading guidelines? Are you reading clinical trials? Are you reading reviews? Are you reading Professor Watanabe's books? What are you doing?
Hi.
Yes.
I'm Ken.
Hi, Ken.
I'm second year of senior resident, so I just started orthopedics.
Yes.
First, I don't know much about the fractures yet, so I read the Professor Watanabe's book first.
Oh, there you go.
And then ask other seniors about the evidence,
right,
and search for the evidence inside the web after that. So actually, I don't search for the things first inside the web, inside the I don't know, clinical studies or in other I don't know, RCTs.
Yes.
I just ask the seniors first, and then start searching for it.
But that's very important, right? Because like for those of us who aren't trainees, we know that when we say something to a trainee, it's very important. And so they are trusting that we are doing our work to ensure that we have the right quality of evidence. So maybe I'll go back to Natsumi. When you had talked about how do we keep up with the best evidence, what are some tips you recommend for busy clinicians to stay up to date? What are the things that they can do so when they have a question about, let's say, hip fractures, they can get very quickly to answers without having to spend hours and hours and days reading every possible paper?
Well, I have to say I'm sorry to Dr. Watanabe, but as Japanese, if you would like to read Japanese guidelines, you need to buy a book, even if you are a member of Japanese Orthopedic Association. So actually, I don't read much of the Japanese guideline. Instead, sometimes I read guideline in other countries or recent meta-analysis or systematic review of the certain problem. Or so recently I got used to how to do the advanced search by PubMed. So for me, it's much shorter compared to before to get to pick up the right article based on my clinical questions.
How do you get access to good information? Where do you find it?
Well, so one of the first things that we have to ask ourselves if we're looking for information is what type of question is it? So background stuff, anatomy, physiology, etc. Those things don't change too much. And so for junior people, they're going to want to say, well, where's the hip fracture? What's the blood supply? Why am I, this is even a question? That's background stuff. But from a foreground point of view, when you start getting into asking, well, should I use a DHS or a nail? Should I use treatment A or treatment B? It's nice to go to pre-appraised evidence that from a trusted source. And because looking at individual RCTs, or as Natsumi alluded to, just doing PubMed searches, you pull up everything. So pre-appraised things. So if you're thinking about medical questions, up to date, and all of these sort of point of care access things are pre-appraised and give you an evidence review, OE example. So you can ask yourself what my PICO question is, who are my patients, my intervention, my comparisons, what outcome, and then go to a pre-appraised source. If you're familiar with advanced at PubMed, then you can go to that, but some pre-appraised evidence things are nicer, quicker, and easier to read, but they have to be from a trusted source.
I think you're right. I don't know, Mark, if you want to speak, or I noticed there's some other, I know to people who have lots of knowledge. I know there's Martin from Argentina visiting online. Thanks so much for joining us. Carlos, I see you here as well. Anyone else who feels like they have something they want to contribute around how do you find information? Because this is the fundamental, right? I mean, we're trying to understand the best optimal treatment for hip fractures in this example, but where do we get that? And you can make a very strong argument that in Japan, the guideline system it's working, but it's a book, right? So if you have to buy the book, it takes time. And Professor Watanabe is saying we've got to go online. We've got to make it much more rapid. Other places, people have found good places to find information. Now, obviously, I'm biased. We're on something called Ortho Evidence right now, and you understand that we'll make sure you all get to learn about what we do. But I'm still curious about what else where you look.
Okay, I think it's a matter of questions.
Right.
When you start doing surgeries and seeing cases,
Right.
you just follow guidelines. But as soon as you're doing cases and you find yourself around complications,
Right.
or difficult cases, then you start having questions. And the patients and cases, it's matter how many questions does this patient have. And then you start searching for information.
Right.
And that's hard work. I mean, because sometimes I have a case and it's not a straightforward case. And then you look for answers, and that's hard work. You have to look one study, another study, and until you find a way out. And cases sometimes not simple. I mean, sometimes cases have 2 or 3 things, or are revision cases, and that's hard work. So when you compare like outcomes,
yeah,
that gives you an idea. But sometimes when you find trials and studies, there's not always what I call what if. I mean, because you read a description for a procedure,
right.
but you don't find there what if this happens or this other happens. I did a case the other day
Right.
which had a pathologic subtrochanteric fracture from a lady who had radiation. So it's not a very common subtrochanteric fracture. She was 66 years old, and she was radiated about 8 years ago, and she's diabetic, and we nailed her fracture first, but didn't heal. So we found that, okay, we need to do a revision case for her. And we thought the best thing for her was like mega prosthesis or oncologic implant, but we don't have that here. So what do we do? Because we know she needs this kind of implant, but we don't have that. So what do we do? Then you look for answers in study and say, well, there are no medications published. And sometimes a case report helps, because someone might have a case like that. So I think one thing that would be very nice to have is answers and questions way to look for studies, because you start looking for, okay, let's look for studies that say hip fractures,
Right,
or implant failure. But a way to look is questions, because you always have questions, and you look for answers in studies, but they're not displayed like that. So
no, I see your point. I like your idea of saying having a database of tens of thousands of questions, and you know, like really Google, all right? Google will say, you know, is this the answer you want? Because you've asked a question, let's see if we can find you the answer through an algorithm. We're not quite there yet, obviously, in medical literature, but I see, Carlos, your point is well taken. And I'll also remind you that we have a session with Mark Swinkowski, who's the current editor of the Journal of Bone and Joint Surgery American, and he says exactly, paraphrases what you've just said, which is, all types of evidence are important, and we shouldn't just discard the case report, because sometimes the case report gives you that one valuable situation where a colleague has faced the exact same thing that you faced. Now, we can argue it may not be evidence-based, and it may not always be, you know, valid in every context, but it gives you at least a starting point and a hypothesis on which you can move forward. Let me ask you all this, and oh yeah, go ahead. Go ahead, Brad.
Just for a sec, Mo.
Yeah.
For some of the residents that are on this session as well, we're talking evidence, we're talking that question, but one always has to put this in terms of good surgical principles. So we just heard that we may not have an implant, we may not have something. So always when you're thinking of moving through the steps and life and becoming a surgeon, always think, what are my standard good surgical principles of fracture fixation or of implant or of stabilizing the entire bone? Think about rules of thumb sometimes, and then also incorporate all of this, not to mention patients' experiences and values, etc. Sorry, Mo, I just wanted to...
No. But Brad, let me ask you this. What do you think takes you from a good to a great surgeon or a great to an exceptional surgeon? Is it increasing technical ability or something else?
Well, everybody always talks about the 3 A's of being a great surgeon, right?
Tell us.
Availability, affability, and ability, in that order.
Mm-hmm.
So to your point of technical stuff, you gotta be a great technician, but great technician, people who are a little bit less technically make things up with the way they communicate to patients, communicate treatment, different types to patients, and with colleagues. So I think by incorporating sound surgical principles and your experience and how you handle your local situation, what implants do I have? What complications have I seen? How do we interact? And incorporating that evidence, I think that takes you to the next level.
And I'll give you a quote that I've yet to find someone who can give me a counter for, which is, a poor decision perfectly executed always results in a poor outcome. So you can be the most technically adept surgeon, the most brilliant surgeon technically, but if you consistently make bad decisions, your outcomes cannot, by definition, be good. And the argument I always say is, to go from good to great or great to exceptional, there's an element of skill that's always involved to get their learning curve, but there's a point at which that will plateau. And you're going to have to then figure out how to make better decisions. And today's discussion is about, how do we get information to make better decisions? Decisions based on data. All of us have seen what's happened in the last 4 months. Everyone's seen. We've seen the crisis that is the information epidemic, and how important good and bad decision makes, right? We've seen it. And that's the big issue for me on the broader question. I'm going to ask, if I could, Abby, to put up 2 polls for everyone. I want you to answer these polls based on what you think is happening with hip fracture care. Today was about hip fractures. So we're going to put up a poll. Hopefully we can get it up. And I want you to answer this. Hip fracture outcomes have dramatically improved in the past decades. Do you believe so? Yes or no, or somewhat? Have we done something with evidence to improve outcomes? And we'll do the next one after that one's got most of us answered in. We'll just wait for a few more. Okay, so we see most of us think they're a little bit better. I want to have a quick discussion on that one, and we'll go to the second question if we could. What do you think? What do you think? There you go. We'll see if we can get that second question up as well. But you see here, it depends on what perspective you use. We've been looking at hip fracture care now for several decades. And you know, when you look at outcomes, it's a difficult situation. And looking at that, I'm going to close this one down here. We'll see if we can put the next one up. Okay, so there's a second poll up. Future improvements in hip fracture care are likely to come from where? So based on your own experience and understanding, where are we likely to make the biggest advances in hip fracture care? Is it going to be some new surgical technique? Is it going to be before the hip fractures, access to care, medical management? Or is it going to be medical management and post-operative rehab? Where's the future going to help us? And certainly it can be all of the above. A few more seconds here. There's a lot of people thinking it's everything. Okay, I think we're done with that poll as well. So you can see now, I'm going to stop this if I could. Okay, there's the results there. So everyone thinks it's going to be coming from many areas. Okay, very good. So let me ask you about mortality. I don't know, has anyone been looking at mortality? I don't know, Mark, you've been looking at hip fracture care. Have you looked at mortality data over time by chance?
Looking, so I don't have an answer, but that is something, yeah.
So what would you say? This audience seems to think that there's been some benefit to mortality over the last 5 or 6 years, or over the last decade, sorry.
I don't know if I have a definitive answer. I would say, yeah, maybe some, or maybe it's become more clear with, you know, some larger, you know, studies out and some better evidence out there to maybe pinpoint it a bit better. I don't know if that means it's gotten better or we just know it better or understand it better. Brad looks like he has something to say.
But no, my question would be to the group. Why do we think mortality is a bit better? What has been a major change in our care that we think collectively that there may be a better mortality, whether there is or there isn't? I'm curious as to what's that key.
So I will say something that from a study we did maybe several years ago. So I'm a little bit, you know, smiling here because I wanted to see if, you know, if people have seen the difference. But we looked at mortality rates over decades. I don't know, Yoshi or Natsumi, if you are aware of some of your, you know, the own specific data in Japan, and you can speak to it. But when we looked at randomized trial data, mortality hasn't really been improved with hip fracture care, right, over many, many years. And that is a bit of a challenge, right? For 5 decades, patients are continue to die. So, and we have to figure out, you know, is the solution a new surgical procedure, or is it going to be some other broader perioperative care? And I'm sorry, I don't want to stop you, Dr. Watanabe. Please go ahead. But that was the challenge.
Yes. And the interesting data is in Japan, the 1-year mortality rate after hip fracture is about, I think, lower than the 10%.
Okay.
It's very different, like COVID-19 in Japan.
Yeah, right. But around the world, it hasn't been improved. I don't know what's happening in other countries.
Oh, really?
But yeah. Oh, yeah. So
I think in the United States, the mortality rate at the 1 year after hip fracture is about 20%, right?
Right. No, that's what I meant, right? Like, so in other parts of the world, it's bigger, right? And it's not getting better. We're not improving. And so part of it is trying to understand what are the features. Do we really believe that putting in a sliding hip screw or multiple screws or a total hip versus a hemi is somehow miraculously saving lives? Probably not. Our own data suggests it might help a little bit with function and maybe not even that much in the first 2 years. And maybe it's less to do with what we do. As long as you do something and you do it well, Maybe it's getting patients to the operating room quicker. Maybe it's, optimizing post-operative care, managing delirium, managing the complications, getting people moving. Those are the kind of questions that I think our field has to happen as orthopedics and team players here. We got to figure out how we're going to solve these problems and what studies we have to do. That's all. It's that kind of question. I'm curious what other people think.
You mean the liaison service, right?
Right. Yeah. Right. So that's another option, right? Is bringing in. I see Martin's gone on mute, so you must have something you want to say, my friend.
Yeah, I think these numbers shows us that the problem is not related to the type of treatment. The problem is related to the type of patient.
Yeah.
So the quality of the patient that has a hip fracture. So it's not like a hip fracture in a car, like in a car accident. It's the fragility of the patients that shows us that after 20, 30 years, the mortality rate, it's still 20, 30% at the year.
I agree with you on that point, Martin, because the challenge right now that we're seeing is, and we've seen it in COVID, right? I mean, I know that we keep going back to these specific issues, but the most vulnerable of the patients have often been hip fracture patients. And I think there's been some early case series data that has suggested that patients with COVID with hip fractures just have just one more, more difficult outcome because of the respiratory, challenges that they had. So it's that, kind of chasm that just gets bigger and bigger. One of our colleagues, Professor Devereux, is a cardiologist, and he came to us 7 years ago or 6 years ago and says, listen, why do you surgeons wait sometimes on getting your patients to the operating with hip fracture? He said, no, we don't wait. We're told to wait. We're told that the patients have to be optimized before we take them. He goes, what do you mean they're being optimized? We had a big debate. And he says, it doesn't make sense because cardiovascular events, myocardial events happen because of increased stress, increased inflammation. And if you don't deal with the stressor, which is the fracture, it's still a nidus for thromboembolism, increased inflammation, increased stress, and all that leads to heart stress. So his argument, and that led to a very big study called Hip Attack, which is rapid treatment of hip fractures. From a medical colleague was, let's get these patients fixed as fast as we can. Think of it like a heart attack. And maybe then we can manage the outcome. And here's the interesting point from that study. You may not have seen this study. It was published in The Lancet. It didn't have a big impact on mortality for all patients, but in the patients that came in with elevated troponin levels, so patients were already in heart stress. You remember seeing this paper, right? In heart stress, came back with a mortality benefit. So in fact, rapid treatment of people in heart stress seemed to actually be beneficial with rapid treatment. So to your point, Martin, it's just that. Treat the patient how you would normally treat the patient surgically, but let's find other system-related issues to, magnify and identify those people most at risk to optimize, the care. But who knows? I mean, that's just one of many, many pieces of that puzzle that we're trying to figure out. And today's been about guidelines and how do we get information and how do we move it? But it's a very interesting dilemma we're in. I also see, friends, that we are right around 8 a.m. Or 1 hour. I do not want to take up another minute of your time because you've been so kind to join us. This is I'm hoping, the psychology of meaningful debate. We've all been on webinars, which is very good for delivering information. I think we get much better interaction in smaller groups. So I know we've had some pushback from people saying, oh, we can't get into these sessions, we can't get in. But you can imagine that we would have never had this discussion unless we had all of us being able to interact and look at each other. So we'll have this on video. We will promote this very widely, and we'll continue to have this debate. But from my side and from Ortho Evidence and from all of you who have become active participants in this discussion, we can't thank you enough. Certainly thank you to our speaker, Professor Watanabe and Natsumi Saka, both who gave really, really thoughtful presentations that got things moving. Thanks to Brad for being a co-moderator today. But everyone, thank you so much. And hopefully we'll see you again. We have many more events, so please join us.